Thank you for this opportunity, ma'am. So mine is a slightly a controversial case and a patient who had an ICL elsewhere and landed up with glaucoma. So a 24-year-old who had an ICL surgery done elsewhere, he had defective vision in his left eye on post-operative day 10, and obviously he's not happy at the age of 24. So before the patient presented to us, he had defective vision, corneal edema, IOP of 24 millimeters of mercury, despite maximum tolerable medical therapy. He was diagnosed as a secondary angle closure glaucoma, and also a secondary procedure of peripheral iridectomy was also done outside, despite a patent hole in the center, and he was diagnosed because of a pupillary block phenomenon. So the PA was done, but still the signs and symptoms were persistent. The IOP was not controllable, and the provisional diagnosis was still secondary angle closure glaucoma, despite a maximum tolerable anti-glaucoma medication therapy. And he was also advised an ICL explantation, and that is when he presented to us for a second opinion. So this was on our plate to actually manage. So when examination was done, the right eye also the ICL was done, but that was perfectly fine. The left eye, obviously a surgical PA was done because of the second procedure at 9 o'clock. Vision was 6/9, and the IOP was 11 and 24 millimeters in right eye and left eye respectively. And this is a clinical examination. The ICL was well placed with the patent center opening. The anterior chamber was deep. The ASOCT was fine, and the 12 clock hours ASOCT vaulting was actually checked. The chamber depth was very much fine. The biometry was done. The vaulting was again checked. It was all perfectly fine. But then we also felt, let us do a gonioscopy and see. And the gonioscopy between the right eye and left eye, it seemed to be slightly heavily pigmented in the left eye compared to the right eye. And the re-diagnosis from a secondary angle closure glaucoma was made to a secondary open angle glaucoma, moving to a normal depth, a heavily pigmented trabecular meshwork, and the normal vaulting of the ICL and otherwise. So we felt there was possible manipulation of the ICL, which could have led to a lot of pigment dispersion in that particular case per se. This was a possible hypothetical mechanism that we felt could have actually caused the trabecular meshwork to get obstructed for him in the first place. That could have caused a lot of liberation. The two procedures may be the reason we could not really hypothesize clearly, but that was a possible thing we felt. And the patient was not willing for an ICL explantation at all. He was a type A personality, and IOP was also not able to be brought under control. So there was two options. Either we went ahead with trabeculectomy with Ologen, keeping in the young age of that particular patient. For this scenario, trabeculectomy seemed a better option than ICL explantation, as the patient had a high bilateral high myopia. So unilateral explantation was not really the right way forward for him. And also, if we explant the ICL, and after that also, if the trabecular meshwork does not recover, then again we'll have to go ahead and do a surgical intervention. So why not go the other way around and see whether we can salvage the ICL at least for this particular patient. So initial presentation, he was on 3 medications. He was on oral acetazolamide, also the carbonic anhydrase inhibitor. Post trabeculectomy, he's doing well. Current follow-up, you can see 1 week, 2 weeks, 30 days, 120 days, and also the 5-year follow-up has been completed for him. His IOP is still in the low teens, and this is the final follow-up picture of the anterior segment, as well as the surgical PA initially done elsewhere. And this is the patent ostium for him. The bulb is healthy and it is functioning, and the patient is happy. His target IOP is well within reach, and there is no structural damage. Functionally, the patient seems to be doing well. And literature also says there is some advanced pigment dispersion secondary to phakic ICL. It has been rarely reported. So the one particular history takeaway is this patient was never done a gonioscopy before he presented to us. So it seems to be something very simple. So there were many flashy equipments in our armamentarium today as ophthalmologists, but a simple gonioscopy actually gave us a clue that the trabecular meshwork is where we need to focus on. And sometimes all we may need is a gonioscopy, which may not be our flashy hero, but at least in this patient it served as a dark night and a watchful protector. Thank you.
Thanks, Prasanna. I just have one question. If you had done gonioscopy before surgery, you would have not done phakic IOL for this patient?
Maybe, ma'am, because we didn't do the ICL. I'm not an ICL surgeon, but
I'm just asking you, how many of you will not do it just because there are more pigments, slightly more pigments in the trabecular meshwork? They will go ahead and do it, because I think lesson here is maybe this was a borderline case of pigmentary glaucoma,
Yes,
which has been missed. And sometimes, surprisingly, you see them most of them come in a very young age group, 20 years and all that. So the subtle signs is what we have to look for. And most often the refractive surgery is more interested in getting the case than trying options to removing it from his list. So that is a problem. So, but anyway, it's a very interesting presentation.
Thank you, ma'am.
I just have a comment. I think I told Dr. Tejas that I don't get glaucomas due to ICL, but we have been in refractive surgery business for 20 years. I do get a lot of primary open angle glaucomas in myos, which is a normal association.
Yeah, correct.
So a lot of patients actually who have undergone LASIK or whatever, they do develop glaucoma as a natural consequence, not because of your surgery. So I think that should be kept in mind. And this gonioscopy being the savior, I may not buy it fully because even as Sujata said, doing a gonioscopy before or after doesn't. The problem, what I can probably connect from the dots is, there was probably a pigment dispersion which you should be able to even demonstrate with the imaging. And there's a heavily pigmentation unilaterally. So that probably could be the reason, and most of these pigmentary glaucomas have a natural course and they tend to go down and the pressures tend to normalize. And it is probably a good option to do a trabeculectomy because obviously you can't wait for the natural course. It will take a long time for it to stabilize. And keeping that, there probably would have been a combined mechanism. He probably was a POAG in evolution, and the pigment dispersion probably tipped the balance.
Other thing we have to keep in mind is steroid response. So
That is additionally,
yeah,
yes.
that is
But
an
it would be
additional.
usually bilateral.
Sometimes, one eye shows more because there's an additional risk factor in that eye. So I have a patient whom I operated 5 years back, and angle is open, everything is fine. She's still on Combigan.
Okay.
So, I mean, these patients probably they were missed earlier. They were missed prior to the
So
surgery.
basically you are preponing their POAG, which would have happened probably over another 20 years later.
Yeah.
So steroid response, pigment dispersion, and probably it was an angle which was destined to become a primary open angle.
Probably it was not a very clean surgery. The surgeon might have led to more pigment dispersion, and then again that would tilt.
There was also 2 procedures, ma'am. Like they again went in and did the surgical PA also. So we didn't have a clear history of what really happened in the 2 procedures. So maybe not an ideal patient for ACL. Maybe don't know, ma'am.
I think surgical PA should avoid. If you need to do the laser PA, try the surgery.
But already there's a central flow, no? These lenses come with this. Yeah, now it's come. Yeah.
It's narrower
Yeah.
and some.
No, earlier, I mean during that era, we were actually trying to do a surgical PA just to make sure that it doesn't close. And we were doing multiple laser PAs.
I
We used to
have
have
one
2-3
question
PAs.
for the glaucoma specialist here. If you come across a patient like this, would you do an SLT?
Oh, okay, that was there. See, ALT would work very well theoretically in case of a pigmented trabecular meshwork.
Yeah.
SLT would also probably, but I think ALT and SLT are for so-called primary open angle glaucomas, not in a case like this where probably the pressures are very high, patient is young, and you can give a trial, but that won't be the salvation. You will not be able to come out of this unscathed even with SLT, ALT. You would still require medications.
It was on
But it
oral-
was probably a good idea to do a safe trabeculectomy because always if you are planning to do surgery, do it early to save the optic nerve rather than to just wait and watch.
it was on
And I think the pressures will probably decide. If the pressures are manageable with medication, you can hold on.
Yeah.
The pressures are too high on so many medications, maybe you can take a call.
We did think about that, ma'am, because of Sertil, the oral carbonic anhydrase inhibitors were also going for him, and we felt there was
That
no.
was a good idea to do a trabeculectomy anyway. All is well, that ends well.
Yes, sir. So far, so good for the patient. Thank you.